Good afternoon. This is Dr. Howard Heft, and I'm here with the Maryland Department of Health team, and we're here today to talk about getting ready for the Maryland Primary Care Program, practice opportunities, and program review webinar. Welcome, everyone. It's a pleasure to have you. We're going to walk through several slides talking about the program, and then specifically talking about the application process, and then finishing up with questions and answers for anyone who may have questions and answers. So let me get started here. First, I'd like to do a quick overview of the total cost of care model. The Maryland Primary Care Program is one element in that model. And the slide here, which will be available to you to review later, really just describes the sequence of events from early in 2014 on through the current time, where hospitals first developed global budgets, and then care redesign programs were developed, and then launching in 2019 through 2026, the Maryland Primary Care Program. The Maryland Primary Care Program is a key element in the overall total cost of care model because we recognize that in order to really manage the care and experience of patients across the state, it's important to focus on their primary care first and foremost. And this slide describes how over a series over time that we will continue to expand and enhance the ability of our primary care providers to do exactly that. The total cost of care model is one portion of the total cost of care model is the umbrella of which Maryland Primary Care Program is one of the portions of that. The other pieces of the total cost of care model include the global budgets for hospitals and the care redesign amendments, allowing other providers to enter into cost sharing and cost savings programs with hospitals and care providers, and then the population health credits, which are unique to Maryland and a key portion of the total cost of care model. All of these things together are designed to manage the health of our high risk and rising risk individuals in the community, who reduce unnecessary hospitalizations, and to provide good preventive care and address additionally the behavioral health and social needs of our patients in Maryland. The Maryland Primary Care Model was built on the backbone or the chassis of our National Comprehensive Primary Care Plus model. But it has several unique elements for Maryland. And on this slide, we'll go through what those unique elements are. The first is the integration with other state efforts. The Comprehensive Primary Care Plus program that's out nationally is an independent model, but as I've just stated, the Maryland Primary Care Program is a component of the overall Maryland total cost of care model and intends to integrate all of the resources in the state in a way around surrounding better and improved health care for our citizens. In the Comprehensive Primary Care Plus model, there was a cap of 5,000 practices nationally, but our Maryland Primary Care Program has no cap. All qualified primary care practices can enter without restriction. The enrollment period for the CPC Plus model nationally was one-time application for a 5-year program, and in the Maryland Primary Care Program, there's an annual application period, so practices can apply this year, now during August of this year, or they can apply in open enrollment periods in the subsequent 5 years. In the CPC Plus program nationally, practices were either in the Track 1 version or the Track 2 version, the more advanced version, and they stayed in those versions throughout the model period. In our Maryland program, practices will either enter Track 1 or in the advanced track, depending on their individual circumstances. But all practices will move by the 4th year into Track 2. So there's a migration from Track 1 to Track 2. The intention is that all practices will move to fully advanced primary care by the end of the program. Practices that are not able to do that will leave the program by the end of their 3rd year and can re-enter if they choose to do so. In in terms of supports to transform primary care. Primarily for the national program, it's payment redesign, but we've added care transformation organizations in addition to the payment care redesign in Maryland. And there'll be more discussion about what exactly care transformation organizations are during the course of this webinar. Also nationally, the CPC Plus program was designed to be a multi-payer program. We are beginning with Medicare only, and to a small extent for Medicaid for those dual eligible individuals, but we anticipate adding other commercial payers and Medicaid as the program progresses over the next several years. And now to get into the actual elements of the program, I'd like to pass it on to Mr. Chad Perman, who is the Director of the Program Management Office.
Thank you, Dr. Hast. Good to be with everyone. So I'm going to walk through both the care delivery redesign and the payment redesign components of the program. Some of you may have already seen this before, but it's good to refresh our memory on what are the requirements of the program, what do you have to do, and what changes for you by coming into the program. So let's talk a little bit about the care delivery side. And so the program is based on 5 advanced primary care functions. Those are access and continuity, care management, comprehensiveness and coordination, beneficiary and caregiver experience, plan care for health outcomes. So those 5 core functions are made up of, are comprised of requirements underneath that practice needs to show that over time that they can meet all of those, depending on the 2 tracks that they're in. So there's a track 1, a standard track, and then there's a track 2, which is advanced. So now let's walk through what those requirements look like. So the first domain, access and continuity, for track 1 practices, they would have to impanel patients to care teams or to a provider. And they would also need to be providing 24/7 patient access. And that means access to the medical records and the health information of the patients in the practice. In track 2, that includes track 1 requirements that you see above here. It also includes alternatives to traditional office visits. So things like telehealth, telemonitoring, group visits, e-visits, all of those need to be provided when a practice is in track 2. And the next domain, care management, which is really the largest focus of the program in providing resources to practices to improve the health of their population. In track 1, there's an expectation practices will risk stratify their patient population. So meaning you would use some sort of algorithm or methodology, whether it's on paper or electronic through EHR, to put your patients into different strata, and then use that to target how you provide care management. The expectation thus also, particularly thinking about care transitions, is providing short or long-term care management depending on the needs of the patient, and timely follow-up after patient hospitalizations or ED visits. In track 2, practices are also required to develop and use care plans for their patients, as well as do medication management for their high-risk patients. I should note all of these requirements that I'm walking through, they are at a minimum for the Medicare fee-for-service population in your practice. But in many cases, it would make sense probably for a practice to be doing this for all of their patients. Comprehensiveness and coordination is the third domain. So track 1, practices are encouraged and asked to coordinate referrals with high volume or high cost specialists that serve their population, perhaps even developing co-management agreements. They're also encouraged and required to integrate behavioral health. So the program gives a couple options of how you can integrate behavioral health into your practice if you're not doing it today. And those 2 options include developing a behavioralist model, which is training someone who's a primary care provider in your practice to handle behavioral health for your patients. The other option is actual co-location of an outside person in your practice, such as a psychiatrist or psychologist who's not part of your practice. In track 2, practices are asked to facilitate access to community resources and supports for social needs. So as you've noticed in a lot of the CMS models and in other programs, there's a real focus today to address social determinants. So this would include screening for social determinants and those needs, and then having a resource inventory that you can direct your patients to, and ideally also get information feedback on those referrals. In beneficiary and caregiver engagement, Track 1 is something that they've used in a national model that they found a lot of success with so far, which are called Patient Family Advisory Councils, or PFACs. And the idea here is to get feedback from your patients in your practice, have a representative group by the practice that allows a better understanding of what the consumer experience looks like, and using that information to improve workflows. In Track 2, there's a particular focus on advanced care planning, given that we're focused on the Medicare fee-for-service population. And finally, plan care for health outcomes. It's the same requirement for both Track 1 and Track 2 practices, and that's to improve your performance on key outcomes. So those relate to the measures that are in the program, which we'll talk about in a minute, but these are both quality measures as well as utilization measures. So as I said, there are metrics, like any CMS program, that you would need to report and meet as well. So the way the quality metrics work in the program is there are electronic clinical quality measures as well as patient satisfaction. The electronic clinical quality measure makes up 75% of the quality score, while patient satisfaction makes up 25%. So for the electronic clinical quality measures, or ECQMs, you would need to report at a minimum 9 of the total 19 measures. And that's the current number of measures they have for 2018. They may revise those very slightly for 2019, and that will be available sometime in the fall. But in those 9, there are 2 outcome measures. Those are hypertension control and diabetes control. These are standard validated measures you're likely reporting today, as well as then an additional 17 process measures across a variety of categories. If you happen to be in a shared savings ACO today, you'll note that the measures are really a subset of those. Patient satisfaction, this is going to be done through a CG CAPS survey, and it will survey a representative population of your patients. On the utilization side, these are measures that drive total cost of care, so ED visits and hospitalizations. These will be specifically for your Medicare fee-for-service beneficiaries that have been attributed to your practice. They don't require reporting on the part of the practice, and the CMS will calculate them. So the other side of the care delivery piece is, well, what kind of payment supports are we providing to help make those changes? So there are 3 major flows of dollars that come from the Maryland Primary Care Program. It's the care management fee, which is the largest of them, the performance-based incentive payment, which is based on those quality and utilization metrics, and then the payment structure for the program. So it's a little different for Track 1 and Track 2. Track 2, you'll notice, increases over Track 1. The care management fee for Track 1 has an average of $17, but that's if a practice had an average number, and every practice looks a little different. So these are per beneficiary per month amounts, and they're for the entire Medicare fee-for-service population that's attributed to your practice. So the range for Track 1 is anywhere from $6 for the healthiest individuals all the way up to $50 per beneficiary per month. And that $50 at the complex level includes the most complex patients in your practice, including those who have dementia or have behavioral health diagnoses. These monies, importantly, are paid prospectively on a quarterly basis, and they are not subject to repayment. The performance-based incentive payment is a $2.50 per beneficiary per month amount that you get, again, for all of those attributed patients. This is paid upfront at the beginning of the year in a one-time lump sum, and then at the end of the year, you report your quality metrics, and it's also paired with your utilization metrics to see whether you've met the measures. The idea here is to give practices the money up front so they can use it to improve their practice, but you have to meet the metrics in order to keep all of the money. The payment structure in Track 1 is still straight fee-for-service. You will continue to bill Medicare fee-for-service in Track 1. The other thing I want to note here is that the performance-based incentive payment, if you're in a Medicare shared savings ACO, the practice would not receive that amount because the practice is eligible for shared savings under the ACO. However, the practice in an ACO would receive the care management fee. In Track 2, Practices receive a much higher care management fee. As you can see, it's $9 to $100 per beneficiary per month. The performance-based incentive payment goes up to $4 per beneficiary per month. And really what changes in Track 2, in addition to those higher payments, is the payment structure. So practices are required to move to a partial prepayment of their historical E&M volume. So this is only for your evaluation and management codes. And you get a 10% bonus on top of a percentage you select. So CMS will provide 4 different options the first year in Track 2 to choose, and that's anywhere from you taking 10% of your historical E&M upfront all the way to 65%. This amount is also paid prospectively and on a quarterly basis. The remainder that you don't take upfront is paid when you actually bill for those services throughout the year. Just a little comment here on macro status. We get a lot of questions about this. And the first thing is the disclaimer, which is at the bottom of your screen, that CMS makes these determinations, and we've certainly tried to outline a little bit of how we think this is going to be working. And if you have questions, you should email them to qpp@cms.hhs.gov. That being said, the application for the program has designated the Maryland Primary Care Program as an advanced APM. It is an advanced APM for primary care providers who are in an organization that has less than 50 clinicians. And this allows you to avoid your MIPS reporting, and you would just report under the Maryland Primary Care Program, so the quality metrics, the utilization metrics, etc. There are other scenarios, obviously, for people with macro questions, including shared savings ACOs, those who are in organizations of 50 or more clinicians, and other scenarios which we've outlined in the link here, and we will share that link with you in the slide deck after this. It's also available on our website. But the main thing here is that if you're a practice, particularly in a shared savings ACO, you wouldn't qualify as an advanced APM under Maryland Primary Care Program. You would be evaluated on the ACO level. So it would depend on the status of your ACO and whether that's an advanced APM. I'm going to talk a little bit about supports for practices, and then we'll talk about eligibility and application, and I'll hand that over. So a little bit on supports. One of the things that we've developed for the Maryland program that doesn't exist in the national model is something called a care transformation organization. These are private entities that don't actually exist today, but they're going through an application process right now. And the purpose of the care transformation organization is to assist the practice in meeting care transformation requirements. It's also important to note that the use of a care transformation organization is totally optional for the practice. The practice chooses if they want to use the CTO and at what level that they would share revenues with them. So the CTO, the idea is to help practices in these 5 areas listed on the left side: care coordination services, care transitions, data analytics, screening, particularly screening for social needs and other needs out in the community, and then general assistance with meeting the care transformation requirements. A lot of what the CTO is designed to do is to provide economies of scale for the practice and provide them the resources and the personnel to meet the program requirements. So things like care managers, pharmacists, social workers, community health workers, nutritionists, etc. So just a little more on the CTO's role in the program, which is, and this is important, is to provide services that are integral to meeting those care transformation requirements, but don't necessarily require the professional services of a physician or provider in the office. So these services are provided under what they call Incident 2 and would be under the general supervision of the provider at the practice. And that's important because it really has to be at the direction of the practice. This program is focused on transforming primary care practices. Some of the things that the CTO might be doing is providing embedded resources, embedded personnel at the request of the practice, or actually providing services at the direction of the practice out in the community. This is similar, if you're familiar with the chronic care management fee that's currently available in Medicare. These types of services are similar to what's allowable under that. A few other program supports for the practices. So we talked about the CTOs. There's going to be a significant data and IT component to help practices look at data and use that to improve how they deliver care. Chris will be providing a variety of reports for the program. CMS will have a portal that's going to have all of your payments and attribution data that will be easily accessible. And then, as we talked about, the CTO will probably provide some additional tools and analytics depending on the CTO. CMS is also very focused on making sure that practices understand how to improve practice delivery and providing them the educational materials and the know-how and the tutoring to do that. So they'll be providing materials, events, peer-to-peer learning opportunities. And then in addition, the state plans to supplement that with some additional practice transformation folks on the ground. All right, I'm going to hand it over now to my colleague, Alex Swinski-Rice, to talk about eligibility and applications.
All right, thank you, Chad. So in order to be eligible to participate in the primary care program, there's a few things that practices need to have in order to be eligible. First, you'll have to pass a basic program integrity screening to make sure that your practice is in good standing with CMS. And there's also a requirement for practices to have a minimum of 125 fee-for-service beneficiaries attributed to the practice. You have to be using a certified EHR, and because applications are going to be submitted for each individual brick and mortar site location, your practice has to be physically located in Maryland. Also, as part of the application process, you're going to need to submit letters of support from your clinical leadership and practice ownership, just indicating that they're committed to the program, and also a letter of support from CRISP, just confirming that you're working with CRISP and able to exchange data. And I'm going to talk a little bit more about these letters later on when we go through the application portal. So beyond those basic eligibility requirements, there's a couple things that practices need to do to demonstrate that you can meet care requirements for the program as part of your application. So for track 1, this means having experience with certain things related to practice transformation, like assigning patients to a practice panel, providing 24/7 access for patients to someone on the care team that has access to their EHR, supporting quality improvement activities, and also doing risk stratification. Keep in mind that all practices will eventually need to move into track 2 by the beginning of their 4th year in the program. So they'll need to meet all the care delivery requirements for track 2 at that time. So specifically, that means that they need to have the ability to offer alternative options for care delivery. So that's things like telehealth or e-visits. And practices also have to have the ability to accept the hybrid payment, which is for the purpose of accepting the CPCP, or comprehensive primary care payment. There's also a few requirements that are specific to health IT that you need to have in order to participate in the program. So as we talked about, you have to be using a certified EHR, and you also have to be able to connect to CRISP, which is the state's health information exchange. At the point when you're getting your letter of support from CRISP, you're going to have to commit to effectively using CRISP services and sharing data by the end of the 1st year in track 2. Also, we talked a little bit about quality reporting already. That's a very important part of this program. So as we mentioned, there are 19 measures that you can choose to report on. So in order to do that, you have to be using the latest ECQM specs for all the measures, and that includes keeping up with annual updates since the program is going to run for several years. And you also need to be ready to report those measures electronically to CRISP. So that data can either be pulled out of directly out of your EHR, or it can be uploaded manually into a CRISP portal. So beyond those eligibility criteria and requirements, there's just a few hard exclusions that would keep you from being able to participate in the program. The list of things you can see here, but practices can't charge concierge fees to Medicare beneficiaries. And there's also a few other CMMI initiatives that have payments which would duplicate or conflict with what's offered through the primary care program. So if you're in one of those models, you would be excluded from MDPCP. And those include the ACO investment model, next-gen ACOs, and the comprehensive ESRD model. There's also an exclusion that if you are a rural health clinic or an FQHC, you would not be able to participate in the program. But there is a caveat here that the FQHC itself is not eligible to apply as a practice site in the program. But if you're a provider that spends part of your time at an FQHC and the rest of your time at a primary care location that would qualify, you can participate through that other primary care location. So now we're going to change gears just a little bit and talk about something that we haven't covered in one of these webinars before, and that's the application itself. So the application portal for practices is going to open on August 1st, and that's less than a week away. So now is the perfect time to be getting ready if you haven't started to already. The full set of application questions and requirements are included in the request for applications, or RFA, which is posted on our website. So you can start reading through the questions now and start preparing responses. Once you're able to officially log in starting in August, the portal is going to save your progress as you go. So you can always save and come back later, but it's also going to time out after 30 minutes of inactivity. So it would be helpful to have some things on hand before you start your application. So some of those things include a list of providers, all the providers at your site, and specific details about them. So their specialty, their NPI numbers, the addresses of any satellite offices. You also want to have tax ID numbers for both your site and your parent organization, if that's applicable. And you'll need to provide names and contact information for a few points of contact that are related to the application, the practice overall, and for health IT. You'll also want to have some patient demographic information, just in terms of what types of insurance you see at your practice. And if you think you're going to want to partner with a CTO, it would be helpful for you to have already gone to the state website and checked out our CTO comparison tool before you start the application. That'll let you know, that way you'll be able to know what your top 2 choices are before you start in the CMS application portal. And finally, it's never too early to start requesting your letters of support, since it might take some time to get both of those drafted and signed. So that's something you can do today before the portal even opens. So once you're ready to get started, you can navigate to the link that we've listed here on the slide. And this is also available on our website under Practice Resources. And when you visit the portal for the very first time, you'll want to click the Register for Portal link, which is where the red arrow is on this slide, right under the login button. And after that, you'll see a pop-up box that'll ask you to enter your name and email. And at that point, the system's going to send you an automatically generated email with a new link to follow, and that'll allow you to set your password for the very first time. Once you already have a username and password, the next time you need to go into the portal, you can just click the main link and just log in using your username and password. Once you get into the portal, the first thing you're going to see is the main homepage. Here you'll see a table that has all the details on the progress of your application, and that'll be where you see the A marked on the slide. You'll also see a button that allows you to start a new application. And on the right-hand side, over by the letter D, you'll see a list of links that might be helpful. So these include a portal user manual that you can go through if you need help. We'll have a series of FAQs, and also a link to the CTO comparison tool. If you click that link, the tool is going to open in a new tab, and you can switch between the comparison tool to pick your CTO, and I'll then come back and switch back to the CMS application. Navigating around the site is fairly straightforward. If you want to skip around to different sections in the application, there's a navigation bar on the left-hand side that has headings for each of the sections in the application. The top right-hand corner has your unique application ID number, so you should reference that number if you ever need to contact the help desk. And every single page in the application is going to have a save button, which will let you save your progress midway. It'll have a save and continue button if you want to save and move on to the next section, and a cancel option. So now I'm going to go through the next few slides very, very quickly, just to give you a sense of the different sections in the application and how the questions are set up. If you've already had a chance to take a look at the RFA, a lot of this content might look somewhat familiar to you, but this should give you a sense of how the questions are set up. So the first section is just some preliminary questions. And for the most part, these are just related to the eligibility requirements and restrictions that we talked through a couple minutes ago. So for example, if you charge concierge fees to Medicare beneficiaries, or if you're an FQHC, you would end up putting that in the application here, and that would exclude you from participating. In the next section, there will just be some general questions asking if you're participating in any other payment models or if you're part of an ACO. And this section is also where you're going to put in all the basic demographics about your practice, things like practice name, tax ID number, address, etc. In the section after that, you'll be asked about your practice structure and ownership. So if your practice is owned by a hospital system or some other type of parent organization, here's where you're going to provide information about the parent organization and how that is structured. So you'll need to know the tax ID number for your practice and also for the parent organization if those are different. In the next section, you're going to provide contact information for just a few key people. So there's 3 categories that you'll need to provide information for, but it is possible for some of these people to be the same person if that's what ends up making sense for your practice. So the applicant contact is going to be the person filling out the application, and this can just be an administrative person. The practice contact is someone who works at the practice and might be a little bit more familiar with the details of how your practice works. And you'll also need a health IT contact, and that's someone who will be familiar with how your practice handles health IT now and someone who will be involved in the health IT requirements for the program. When you click each of those links, a new pop-up box is going to show up, and it's going to ask you for contact details for each of those people. So you'll just need name, email, phone number, and an address for each of those. When you're done, you just press save on the pop-up box, and you can move on to the next person. And after you're done with those 3 general contacts, you'll need to fill in more detail about the clinicians and the staff that are going to be participating in the program. So this is one of those sections where it's really, really helpful to have the information on hand before you get started. To start, you're going to need to fill out the number of physicians, nurse practitioners, physician assistants, and clinical nurse specialists that are just in your practice overall. Once you've put in those numbers, the application is going to ask you how many of those are actually going to be participating in the program. And for each clinician that's participating, you'll have a separate pop-up window where you'll be asked to put in more information about each of those individuals. So that'll include their name, their NPI numbers, license numbers, specialty, and also whether or not they practice at any other locations. Once you're done with the staffing details, you'll move on to practice activities. So the questions in this section basically just have to do with what kinds of services your practice provides, and if you've achieved certain types of recognition, like the NCQA Patient-Centered Medical Home recognition, you can list that here as well. In the Health IT section, you'll have the chance to list the different types of Health IT software that you're using. So the most important information to put in this section is to list the EHR that you're working with, but you can also add other things like data analytics or care management software if you think that's relevant and helpful to your application. So to add software, you just click the New Health IT Vendor button above the table, and you'll just have to enter a vendor name, product name, and the version number for each of those. This section is also where you're going to need to choose one of 3 options to indicate your level of connectivity with CRISP. The next section is going to cover patient demographics. So here you'll be asked to estimate what percentage of your patients have different insurance types. So what percentage of your patients have commercial insurance, Medicare, Medicaid, and how many are uninsured. This can either be an actual percentage if you have that information in your EHR, or it can just be your best estimate. After that, you'll come to the care delivery section. So this is one of the longer sections in terms of the number of questions, just because it goes through each of the 5 primary care domains, and it tries to assess where your practice is currently in providing service under each of those categories. So it's okay if you don't have all of these things in place when you apply, because the whole purpose of the program is to help your practice transform to meet these requirements. So some questions are going to ask about where you are currently. Other questions will ask what you're willing to do to be able to meet care transformation requirements in the future. But just keep in mind that you're not expected to have every single one of these things at the time that you apply. After filling that out, you're going to move on to the CTO section. So a couple things to keep in mind here. Partnering with a CTO is completely optional. So if you think you can meet the care transformation requirements without the help of a CTO, that's totally fine. You can leave this section blank and go on to the next section. If you would like to partner with a CTO, then this is where you'll indicate your top choice and a backup choice for CTO if for some reason your first choice becomes unavailable. Another thing that I want to mention here is that as of today, the tool isn't live yet, just because CMS is still making their decision about what CTOs are going to be available. So right now, this link takes you to a landing page that lets you know the tool is coming soon, and we expect it to go live on or around August 1st. Once the tool is ready, it's going to let you narrow down the list of approved CTOs to just the ones that are providing services in your county, and then you'll be able to see more detail on each one. So once you've picked your first choice and made a second backup choice, we just ask that you enter the full CTO name and ID number into the fields that are provided in the CMS application. So finally, when you're done with all the application questions, you'll come to a section where you can upload your letters of support. So again, you'll need letters from clinical leadership and practice ownership saying they're committed to the program and meeting the requirements, and also a letter from CRISP. So we've made the CRISP letter very easy to request, but we would like to ask that you request your letters soon, just because you need to make sure there's plenty of time for both parties to sign off. So we have a bit more detail in an instructions document that's on our website, and also provided a link here. But to give you kind of a high-level overview, to request your letter, you go to our website and download a Word document template that we have uploaded on the site. You fill in the template with your practice information, put it on your practice letterhead, and then send that document to CRISP via email. CRISP will come back to you and let you know if there's any other steps you need to take to get connected, and then they'll come back to you with a signed letter, and you can load that directly into your application. So finally, as the final step, you'll just be asked to certify that everything in your application is true and complete. You'll have the chance to preview your application. You can download it as a PDF. You can go back and make changes if you need to. And then when you're ready, you just press the submit button and you'll be all set. So what happens after you press the submit button? So let's just take a quick step back and look at the overall timeline. So the CTO application period has just closed and CMS is reviewing their applications right now. Once that review is complete, we're going to post a list of the approved CTOs in the comparison tool, so you should have a list ready to select from at the time you're ready to apply. The application period for practices opens next Wednesday, August 1st, and it's going to be open through the end of the month until August 31st. So once you submit your application and the deadline closes on August 31st, CMS is going to take the next month or two to review applications. You should probably hear back about whether your application was approved later this fall, probably late October or November. And once you know whether or not you've been approved, CTOs and practices are going to sign their participation agreements with CMS and also agreements with each other. So the program is going to officially kick off January 1st, 2019. But if you didn't get in this year, or if you want to hold off before making a decision to apply, we're going to have an annual application period, probably around the same time each year, that'll run through 2023. And the entire program is going to run through 2026. So for any practices that apply in 2023, they'll begin in 2024, and they'll have 3 years to participate in the program. So with that, I think we can take a few minutes and look at the questions that have come in the question box.
Yeah, so if you have questions, please submit them through the question box. We will read them out loud and then do our best to answer all of them. Thank you.
Okay. Let's go through some of the questions now. The first is, do the practices have to pay for CAP survey? The answer to that is no. That's provided by CMS and no charge to the practices. The second question is, can the CTO require me to change my practice workflows? The answer to that is no. The CTOs are working to support the practices. They may give suggestions about workflows that could be enhanced or improved to make it consistent with the our Maryland Comprehensive Primary Care Program, but the CTOs work for the practices, so they wouldn't compel you to change anything. They may be making suggestions, however. Third question is, will CMS use the current CAPS survey, or will the practice need to contract with a vendor to conduct an MDPCP specific CAPS survey? So I believe that the CAPS survey will be the generally available CAPS survey, and the CMS will contract with a vendor to administer that survey to your patients. The next question is, do you stop billing CCM codes for Medicare patients after you join this program? And the answer is that when you join the program, you would no longer bill CCM codes. If CCM codes could be billed for patients who are not part of the program, but for any patient who is attributed to the program, then you would not bill for those. If you happen to bill for them, CMS would just simply deduct that from the care management fees. Worthwhile pointing out again that the CCM codes are opt-in for patients. There's a certain requirement for a certain amount of non-face-to-face activity for those patients during the month that needs to be accounted for on a monthly basis. And CCM codes are only for those patients who have the qualifying conditions. And for the care management fees, it's for all the attributed fee-for-service beneficiaries. There's no person-by-person accounting, and it's not an opt-in. So it's much different, and we believe it's broader and more beneficial. So the next question is, who are clinical leadership to get the letter of support from? That's whoever the clinical leader in the particular practice is. You self-designate who that clinical leader would be. You need to have multiple user accounts for multiple applications.
So we got one more question about whether you need to have multiple user accounts for multiple applications, and the answer is no. If you're within the same tax ID number, you can just have one username, and on the home page you'll have a button to start a new application for each of your practice sites.
And a new questions come in is, will there be a public listing of providers who are selected to participate in 2019 in the fall? We're not aware now of CMS posting any public listing of the practices. There's no prohibition for practices indicating that they are participating in the program.
There's a question, do the practices and CTO draw up their agreement, or does CMS provide a templated agreement? I think this is referring to an agreement between the CTO and the practice to deliver the care management services, which is separate from a participation agreement directly with CMS. So the answer to that is that I believe a templated agreement is going to be made available that practices and CTOs will be strongly encouraged to use.
There's a question, what if the doctor retires after starting the MDPCP program after 34 years? Not sure. So the program itself, let me break that up into parts. The program itself is designed to be 2019 through 2026, so it has an 8-year run. The anticipation at the end of that period, or sometime in the years prior to that, is if the program is successful in meeting the program requirements, that is, it either improves the quality of care of those recipients or of the beneficiaries who enrolled in the program, and or it lowers the cost of care, the total cost of care for those recipients, that it would be converted then into a permanent program. So the anticipation is that 8 years is a model program. It will be studied during that period of time, and then if successful, which we anticipate it will be, it will become the permanent way that we deliver healthcare in the state. Although that is to be determined. The ability for an individual to retire and go out of the program, the providers can certainly leave the program at any time. If they leave, then their patients at that practice site stay in the practice. They will continue to be practice will be continue to be in the program. If it's a solo practitioner who then leaves the program, then they would terminate their participation in the practice. There's no particular retirement program within the practice. It's either providers are in the program or they're not. Chad, do you have any other comments on that?
The only other thing I would say is that if a provider, whether they retire or go to another practice, leaves the practice, CMS will require you to update your roster so they can adjust the roster and rerun the attribution for the practice. But that's simply it. The practice, as Dr. Hess said, would stay in the program.
Another question, is there a downside to the hybrid payment in Track 2? I think that would be certainly a question that you may have in terms of interpreting how the hybrid payment is utilized within your practice. The upside certainly is that it's an increase by 10% over what your historical payments would be. It's given in a lump sum on a quarterly basis so that you have more flexibility to use those dollars. And the upside is that you can pick how much of your payments, what percentage you want to have in that comprehensive primary care payment. The downside would be it's a different way to receive payments from CMS for those patients. So it's a matter of having to understand the best ways to utilize those advance payments. But other than that, I don't know of any particular downside for those payments.
We're getting a lot of questions, so we're just gonna organize them a little bit, and just hang on 1 second here.
Okay. The next question is, our organization will be applying under Track 1. What criteria would MDPCP use if it deems that the practice should instead be applying under Track 2? I think typically if you apply under Track 1 that you would stay in Track 1 because it would be indicative to CMS that you're not prepared to take on the comprehensive primary care payments yet. Next question is, if you have 2 locations in Maryland, do we apply for each separately or just the main and then add the other as a satellite? Each brick and mortar location is a practice in itself. So it would be two separate applications. Okay. The next question is, I'm concerned about the 125 attributed member requirement. How are the attributed members calculated? The attribution is done in a stepwise fashion by CMS. So patients would be attributed to you first and foremost, if you've done any CCM billing for those patients in the last 2 years. Second, if you've done any annual wellness visits for those. And next, by the plurality of visits that the patients have shown to your practice for E&M code visits. So if the patient has been to your practice for 5 times in the last 2 years, but to somebody else twice, they would go to your practice because you have the plurality of visits. But if you've done either of the AWVs or chronic care management codes, that would take precedence over the plurality. And then CMS will do an attribution at the time of your registration to see if you have 125 patients who have met those general criteria.
Great. Any last, these are great questions. We've gotten through all of them that come through. Or any other questions that you have out there? I also should say that we are going to have some additional question and answer periods coming up. CMS will be having a webinar that they're doing, and then we will also provide some additional opportunities to ask question and answers. In addition, on our website, there are a variety of materials, including an FAQ document.
Yep, and just to be more specific about the upcoming Q&A sessions, we have 3 scheduled for the month of August. One will be next week, also Thursday at 5 p.m. on August 2nd. CMMI is going to be running one on August 7th at noon, and then we'll do one final session right before the application period closes on August 23rd, also at 5 p.m. And the details to register for all of these are on our website on the public calendar.
And we will continue to do everything we can do to answer every question that you might have, make sure that you fully understand the program and you can make good determinations about whether or not this is right for you.
So the question, so one more question came in. Can a practice have more than one user with a login for the application portal?
No, I don't think so.
Don't believe that you can do that. I think it is one login. Of course, you could, I guess, share that internally, but it's just one login for the application portal. Terrific. Well, thank you very much for joining us. Dr. Haft, do you have any final lasting words for our practice brethren out there?
No, it's just only that we're really looking forward to your potential participation in this. I think it's going to be a great program for our primary care providers to give them more financial support, more technical support, and particularly to enhance the ability to take the best possible care for our patients in Maryland. That's our ultimate goal. Thank you all very much for participating, and look forward to hearing from you in the future.